at the outset, I am very much thankful to yeah, uh, I am very much thankful to Sharda madam. Thank you very much, madam, for honoring me and giving me these talks consecutively every month. वंदना जी और बाकी सब दिल्ली गायनेक फोरम के जो भी सीनियर्स है, मैं सबका शुक्रगुजार हूँ एंड आई एम वेरी मच थैंकफुल. टुडे आई एम गोइंग टू डिस्कस द एनीमिया मुक्त भारत ओवर simplified. Purposefully, I have given this title because I have taken the inspirations from Sharda madam, and you always what she says, he try to make the topic simplified so that maximum people, if they utilize those things in their practice, then the maximum portion, problem portion, that gets solved. And for hi-fi cases or for hi-fi investigations, let some other people work. And I think that is the real message. We all know that Anemia Mukt Bharat is our dream. And if we want to do this, every one of us should be very serious while dealing this anemia. And if we ask the question to ourselves, are we really serious? After hearing this lecture, probably the 50% of all of us will say, yes, we are really serious. But many of us will say कि अरे हाँ ये छूट रहा था, ये करना चाहिए, वो करना चाहिए. I have just made one thing which is a very simple thing. We are talking anemia in pregnancy. So I say screen all by CBC and peripheral blood smear. What happens? Ki many a times it is said that screen with hemoglobin, but it is not the case. Ideally, complete blood count and that too along with peripheral blood smear should be done. If PBS is not available, at least complete blood count must be done. Now, once such report comes in front of us, we must see the blood indices. And we are doing so many series where we are really going out and teaching all the colleagues, doctors, the ABC of CBC, because we must understand what are the blood indices and what is the importance of them. And just by looking these blood indices carefully, we can diagnose almost, I can say, 90% of the anemias. And very few anemias, they require the hi-fi hematologist investigations. Otherwise, maximum things they can be done in our chamber itself. So when such mean corpuscular volume is less than 80, immediately, without hesitation, we must do ferritin and
Sir, your voice is gone. Some
No, no, I think it's because of the internet.
network.
He
I
will
think
come back.
electricity issues. Yeah, yeah, maybe.
He will come back.
Yeah.
I think the point which he has emphasized, this particular slide, he will quote it again and again, that, screen all patients, not only by hemoglobin, but CBC and peripheral blood smear.
That's very
Secondly, whenever you find the MCV levels are less than 80, please get your ferritin levels done as well as TIBC. Electrophoresis should be always done whenever you find that the patient need to be screened. All patients of thalassemia need not have hemoglobinopathies, need not have a low hemoglobin. Sir, are you there? Yes.
not. No, he's logged out.
No,
He's
he's coming.
Yeah,
He's
yeah.
coming.
Unmute yourself, sir. Unmute
Sir,
yourself.
unmute yourself, sir.
Yes, yes.
Unmute. Ah.
Actually, light came na, so it disturbed.
Don't worry.
We
Don't worry.
understood. We
We are
understood. Yeah.
eagerly waiting.
Yesterday, ma'am, also there was such an important day regarding anemia. Na? It was National Deworming Day.
Correct.
Yes, yes, yes.
So,
Deworming day.
yeah,
Yes.
yeah, it was there in the news. And Haryana, they came up with such a large project, deworming everyone at PHCs, schools, and everything. I think this is one strategy which.
Doctor, you must remember Dr. Gorakh's lecture last time. He said he
Yes.
has
All
made a
OPD.
practice to give each and everybody, people who are coming to the OPD, whether relatives or patient, he
Yes.
deworms them, and he feels that 25 to 30% of anemia can just go away by just deworming.
Yes, madam. Madam, am I audible and visible?
Yes,
Yes, sir.
yes.
Yes, sir.
No, visible नहीं है. Slide आपकी visible
नहीं,
नहीं.
you're visible. Yes, you are visible.
You
अच्छा,
are
slide
visible.
नहीं
The
दिख रहा
slide presentation is not visible, sir.
है. Okay, just a minute. What happened? I'm sorry.
Your screen had come, sir. Your screen had come. You have
Ma'am,
to
वो
only.
blank आई थी. He had to reshare it.
Yes, madam. मैं रीशेयर कर रहा हूँ.
Right.
मैडम आ गया.
Yes,
Yes.
yes. Yes.
Make it full screen.
जी.
Yes. Make it full screen, sir.
That's it. That's it.
And hide this here.
That's right.
Sorry. Right. So whenever this mean corpuscular volume anybody sees कि it is less than 80, then a alarming situation, because what happens when we read the level of the ferritin, it is written in all lab parameters as 10 to 110. So that means the ferritin level, say for example 10.5 is the same we are taking, and 110 also we are taking as the same. So which is very wrong. And that's why one should understand that a ferritin level of 30 to 35 should be the baseline, which is supposed to be, that should be the level of the ferritin whenever the patient is pregnant. So if we keep that in mind, and if the ferritin is less than 30, then that clear cut gives us idea if my patient is of iron deficiency anemia. Most of the time, or the olden day teaching was in a such a way that ki, Are, when MCV is less than 80, why you are worrying? Just start iron. But in that approach, what was happening, as madam was also saying one day, कि we used to start only one tablet of the iron. Then डॉक्टर भी बोलता है कि एक महीने के लिए आप खा जाओ, पेशेंट भी उतना सीरियस नहीं होता. And are we using the correct doses of the tablet of the iron? The answer is no. Because we are again making here one confusion. I am going to come in detail later on, but let me clear that the prophylaxis in the ANC period, that dose is different, and the treatment of anemia, the iron dosage is different. And most of the time, we keep a fear in the mind that my patient may have the side effect of the tablet. But usually it doesn't happen. Many times it will happen. We have to counsel the patient. Again, we should not do these iron studies half-heartedly. Only sending the ferritin, it will not suffice our job. Ideally, at least TIBC, that is total ion binding capacity, that must be done at least. Again, here I want to clarify. We are saying when the MCV is less than 80, only in such cases. So we are not wasting the national burden. Second thing, when we want to do anemia Mukt Bharat, such aggressive step must be taken. And third, all the government labs nowadays they are providing these iron studies, ferritin studies free of cost. In fact, I got a call from my sub-district hospital that we have come to know that you are sending these investigations, but our labs they are devoid of such referrals, so you can send your patients to our OPDs to get these investigations done. So that much pro approach is from government. Then if we also make a hand with them, definitely we can reach our goal. Next is the HB electrophoresis. So whenever we want to do, should be done by HPLC, because again this HPLC method is very much sensitive and it does not give only abnormal hemoglobins, but other all rare types of hemoglobins are also given by these methods, and that's why HPLC. Again, when such blood indices they show that ki MCV is more than 100, then straight away our olden day teaching was कि अरे this is a case of folic acid or B12 deficiency, दोनों को दे दो. No, ideally we should do the retic count, because again that is going to differentiate. So these clinical investigations, we should try to do it. And all investigations which I have given here, they are must, ideally mandatory if we want to do anemia Mukt Bharat. Otherwise, doing haywire investigation of CBC and considering that all women are nutritionally deficient and giving them iron, we cannot eliminate the anemia. Next is injectable. A concept should be there in our mind. How one thing we should know when we are using these injectables and when we promote these injectables. See, the injectables, those with dextran component, they were giving anaphylaxis. Nowadays, these FCM or the different maltoses which have come, they are very, very safe because the dextran component has now gone absolutely out from these injectables. Now, even we should not utter the intramuscular injection in our lectures also. We should bold enough saying that we should use IV injectable iron for all moderate and severe anemias from second trimester onwards. That should be the bold statement. Then deworming. Deworming of all OPD patients. As madam was saying, yes, we have done that experiment where in our OPDs, all non-ANC women, let it be medical representative, relatives, or anybody that will visit our clinic, we give them one albendazole tablet, and that has shown there is very less means I can say negligible patients which come from outside. In our area, in my practice, we have reduced anemia by that much percentage. Almost we have calculated more than 25,000 people till then are now dewormed. So that is very important thing. And simple approach was done. One pharma company, actually they do not produce even that deworming tablets, but they wanted to do something for the clinic. So I told them, in spite of doing some activity for myself, better to do for the patients. Please purchase deworm tablets for us, give, and we are telling the company or even patients that so and so company is doing the activity for you and this is a free of cost tablet. Simple such techniques can be done. Another question to all of us, including me, are we doing deworming of all pregnant women at 28 weeks? When we are giving the lecture of ANC, we are saying that. But practically, are we giving deworming to all pregnant women at 28 weeks? Probably answer 100% will not come yes. So that I think we have to do. Last two approaches are iron orally to be given 200 milligram in treatment. Means when we are treating the anemia, the dose is 200 milligram. When we are using the iron for prophylaxis, dose is 100 milligram. And last thing, we should not forget the proteins, because many a times I have seen that when we are prescribing the treatment for anemia, we are prescribing iron, no doubt, and we assume that a sufficient amount of the folic acid is there inside the iron. But I think we should be uh, we should see those tablets. What type of folic acid is there inside that iron tablet? How much milligram is there? And if it is sufficient, then fine. Otherwise, additional supplementation of the folic acid and vitamin B12, that must be given. Now let us start with few slides. So hemoglobin less than 11 gram during pregnancy, iron deficiency anemia, which is commonest in Bharat, B12, folic acid deficiencies, these are again common. Rest, I am not saying they are uncommon, but again, there are certain pockets where certain anemias are more common. We should not ignore the mild anemia, because mild anemia has depleted iron stores. When we are doing, madam, now a study, those patients with hemoglobin between 11 to 12, we are sending ferritin TIBC of all patients. As a study now we are doing. And in that, almost 80 patients we have already completed. And ये एक आश्चर्य की बात है कि almost more than 60% of such patients with hemoglobin between 11 to 12, that means by definition they are not anemic, but still they have depleted iron stores. And now these patients are more dangerous, because as the pregnancy will advance, again these depleted iron stores, that will reduce their hemoglobin very fast. And this again, if you remember, while talking on thyroid, I put a concept of gestational hypothyroidism, means, or there is a concept of gestational diabetes. Likewise, now I want to put a concept of gestational anemia or gestational iron depletion, because these are certain patients which are on the verge where hemoglobin is 11, but iron stores are depleted. And as pregnancy advances, hemoglobin goes down. And then what happens? We think, already iron tablet is going on, and why still hemoglobin is coming? Because whatever we are supplying is not sufficient, because we are treating hemoglobin of that patient, but we have not seen the iron stores. So that is a problem. So serious attention must be given towards the management of anemia, even if it is mild. Again, I remember in one talk of anemia prior, I have given the diet advice. And rational diet advice is very essential while counseling the pregnant women. Why I am focusing these points? Because we all know how to calculate the dose and etc. But these points, I think they are important when we are thinking anemia Mukt Bharat. Because the commonly prescribed so-called iron-rich food sources, they do not contain much iron at all. Means we tell कि dates खाओ, cashew nuts खाओ, almonds, beetroots, carrot. But do we know these things, they contain less than 10 milligram iron per 100 gram. We always tell मूंगफली खाओ, मूंगफली का लड्डू खाओ या चिक्की खाओ. But have we ever checked what is the iron that is being that goes through this diet? The answer is no. There is a beautiful paper by Gopalan sir, who was then director of our ICMR, and at that time I am going to show that, and he has shown that the easily available things like garden cress seeds, means haliv, that is the richest source of iron, which gives 100 milligram iron per 100 gram. देन लोटस स्टेम ड्राई, जिसे हम कमल ककड़ी बोलते हैं, नाइगर सीड्स, देन कॉलीफ्लावर ग्रीन, देन अमेरैंथ ट्रिस्टिस, जिसे हम राजगिरा बोलते हैं. These are the true iron rich food sources which are easily available in any मंडई और any बाजार. कहीं पे भी ये मिलने वाली चीज़ें हैं और सादे सिंपल लोगों को हम ये खाने को बोल सकते हैं. So this is the chart. This is by Gopalan sir. Nutritive values of Indian foods. This is by ICMR. And if we see this chart, then we will see ki are this one is the dates, etc. That is not even in this list. See, at the bottom I am showing with the arrow that we commonly advise dates which contain 7.3 per 100 gram, cashew nuts, almonds, beetroot. We always tell कि बीट खाओ और लाल हो जाओ. गलत है, because it is giving 1.19. Carrot, which is giving 1.01. So these are the best things which we should actually tell our patients. So we are wrong in advising the iron rich contents, and that's why the patients are actually they are not getting the correct advice. That is maybe, but I have to say this. Now all pregnant women must be screened with complete blood count based on MCV. We have to do iron studies, high performance liquid chromatography, HPLC for, as I said, for sickle cell, for direct identification of sickle cell disorders and thalassemias. Iron studies, how they are going to help to confirm the diagnosis, to quantify the deficiency, to justify the parenteral therapy, and to avoid the iron load. So we should see towards iron studies in these ways. Public sector, as I said, it is available and done free, cost effective when morbidity and mortality out of iron deficiency is considered, because WHO says 32.4 million pregnant women suffer from anemia, and India it is 40 to 60% prevalence amongst various states. Now this is a chart which I would like to share, and this one chart is sufficient. If we have this chart, we can diagnose any damn type of anemia. Very simple thing I would like to explain. I will explain with the arrow. When HB is less than 11 and low MCV, we should see the RDW, that is red cell width. Now with high RDW, when the high RDW is high, then we should suspect the iron deficiency anemia. And immediately we should do iron ferritin TIBC. Now you will become surprised why I am telling this and stressing this, because this will give 4 types of diagnosis. This is not only giving the iron deficiency. See how. Now we are following this and we have done this. Now there is low iron. Ferritin is also less than 30. TIBC is high. Our diagnosis is iron deficiency anemia. But when the TIBC is low, then is it a diagnosis of iron deficiency anemia? Then no, answer is no. That is an anemia of chronic infection. So unless until we treat this chronic infection, we do diagnostic studies for this, we cannot get rid of the anemia. Third, patient may have high iron and normal TIBC, but patient will have low MCV. And in these cases, probably it is a case of sideroblastic anemia. So this is how these tests they are going to differentiate. Next, when patient is with low MCV and normal or low RDW, then probably we have to suspect the thalassemia. And here I will say, in spite of doing these, straightaway we should do HPLC. Again, in patients where ferritin is more than 30, we should directly do HPLC, because that will give us the direct diagnosis whether this patient has thalassemia or any hemoglobinopathy. No third diagnosis, because it is very, very, very simple and clear-cut diagnosis. Next type of patients where hemoglobin is less but high or normal MCV, usually high MCV, we should do the reticulocyte index. Because again, this reticulocyte index, if it is low, this suggests the megaloblastic anemia, and this will show either B12 or folic acid deficiency. Here again, yes, here I will not say to do the B12 or folic acid levels, because again these levels are very much costly. So here we can directly supply B12 and folic acid together. Again, one must know in cases of those with are MTHFR gene problems, those who go with hyperhomocystinemia, there not only folic acid but B12 and folic acid should be given together, because that will be effective. Similarly here, when patient is with high MCV, low reticulocyte count index, we should use B12 as well as folic acid together. Again here, if MCV is more than 100, please use injectables. And we should not be very much worried about using the injectables, because those will give the immediate and fast effect. And further maintenance will be done for coming 1 or 2 months with the tablet folic acid or
ये मैं
B12.
दांत के चक्कर में नहीं खाऊंगी, ये मैं संतरा ले लूंगी.
So carry on.
Carry on. Okay.
Yes.
Right. Again, when suppose we feel that along with this high MCV, when MCV is high, but there are low WBC and low platelets. So this clear cut indicates automatically we have the CBC report in our hand. So if we have low WBCs, little low platelets, but MCV is high, so that means all cell lines, they are in primitive form. So probably I am dealing with some aplastic or myelodysplasias. Now comes the picture of hematologist, and when we come across with this CBC report, anemia with high MCV, with low WBC, with low platelet, no other diagnosis. And better that we should refer such case to hematologist. Mane, we have not done any high-file investigation, but we have suspected aplastic anemia or myelodysplasia. Now again, here we have done for high MCV the reticulocyte index, and reticulocyte index is high. So when the reticulocyte index is high, that itself suggests that some sort of hemorrhage is there inside the body, and body is trying to recover all those RBCs. Here comes the role of PBS, and if PBS has cystocytes or microspirocytes, it is a case of intravascular hemolysis. If they are absent, and definitely there will be the history of hemorrhage. But again, this is very important. The PBS will give us the cell lines. PBS will give us the presence of cystocytes, microspirocytes, and then probably it will give us the correct diagnosis. One more thing. If we are suspecting anemia of chronic infections, we should think right from pituitary, thyroid, then even the liver infections and the kidney infections, because these four sites are very important, and when chronic infections on these four sites, they lead to anemia. So if we use these schematic diagnoses, I think almost all diagnoses, they are covered. Again, here I would like to say that when patient is coming from some area which is more prone for either sickling or either thalassemias, straight away we should go for HPLC. In cases of sicklings, again, Government of India has given us clear-cut guideline. The baseline test should be done, and depending upon that result, we should go for the further test. But again, these are smaller pockets from certain parts. And now here I remember the second year of our MBBS, where we were being taught that we should know the origin. So in our clinic, it is a practice that we not only ask you where do you reside, but we ask you where are you from. because that gave me the idea when one of my patient, she was actually working here at my place since so many years, but she said that "Yeah, I am from Amravati and Amravati is near Nagpur." So then I stuck, oh, that area is more prone for thalassemia and sickling. And only I requested her, "Ki, let us do straight away HPLC because you were again hemoglobin is 10, 11." She was actually coming to me for fertility treatment. And yes, we found that she was thalassemia minor. So that means this geographical location of the patient, that is very important on the history. This is the last variety I want to focus is a dimorphic anemia. Here, peripheral smear, it will give us the correct diagnosis. Because otherwise, most of the time what happens, when we are using the machines for the, that is cell counters for the hemoglobin, then what happens, which types of cells they come on that probe, the machine will give that diagnosis. Most of the time, dimorphic anemia is not given by the machine. So, but here again we have to think, when RDW is too high, probably it is a dimorphic anemia. And when it is there, when the folic acid along with iron deficiency is there, B12 and iron deficiency is there, thalassemia minor and B12 deficiency is there, iron deficiency with hemolysis is there, or folic deficiency with hemolysis is there. So all these pictures, they will give us the dimorphic anemia. So one should not think that "Ki, "Arey, I have not seen." I will say here, ki, we cannot say that. Probably we have not diagnosed it. But most of these combinations, they are present. Even pernicious anemia with atrophic gastritis. Again, there is iron deficiency along with B12 deficiency. And that will give us the clear cut picture. Again, in our area, again, I will say the Western Maharashtra, I do not know about the northern states, but hookworm infestation is very much rampant. And that's why the iron deficiency anemia and even the hill में जो cracks रहते हैं, crack hills etc. that is very common in our area because again these are the farmers and all. And so these hookworm infestations, and again along with that we have seen we are the people who are taking too much tea. So again atrophic gastritis and pernicious anemia, that is again very common in our area. Now coming to the last part, management. Again, for mild anemia, this is absolutely as per based on the Anemia Mukt Bharat practical operational guidelines. So there is nothing I am talking from my IME, my business, which is absolutely based on this Anemia Mukt Bharat guidelines. So recommended dose in the treatment of IDA vary from 60 to 200 milligram of oral iron, elemental iron per day. Again, I have purposefully written that elemental iron, that we have to think. WHO recommends 120 milligram plus 400 mcg folate, while Government of India guidelines says 200 milligram plus 1000 microgram of the folate. That means simply they say 2 tablets of iron and folate when the tablet is of 100 milligram. Hemoglobin, we have to repeat. That means complete blood count. We have to repeat after 4 weeks of the oral iron. We have to see if HB is not raised or lower iron is not tolerated. We have to go for sucrose or ferric carboxymaltose. Moderate anemia, parenteral iron therapy. Again, somebody may ask, what about till second trimester? Nothing can be done. We have to use oral iron. We have to go for the dietary source and etc. But then onwards, parenteral therapy. Severe anemia. Again, severe anemia, remote from the turf, can be managed with IV iron preparations, blood transfusion, only in severe anemia with decompensation, with without signs of cardiac failure, along with the help of physician, we should use those. This I want to focus a lot. That is oral iron preparations and the facts. These literally, madam, we have kept one book, notebook in our medical. There are 3 medicals where our patients go because I work at 2 different places. And what we have done, we have kept one notebook and we see that which iron tab we have explained our patients कि ये गोली अगर आपको हजम नहीं होती तो आप मेडिकल में आके बिन दिक्कत ये वापस देके जाओ और दूसरी टैबलेट लेके जाना. So there is a notebook and we check that which tablets they come back and which tablets they usually do not come back. And then this is the experience what I want to share. Ferric sulfate polymeric complex. It is the best tolerated oral iron preparation with good compliance. Second, ferrous ascorbate and ferrous calcium citrate. They come on day number 2 and 3 when the ferrous sulfate is not tolerated. Only these 3 iron preparations are sorry, number 1 best tolerated and number 2 they give us the best results. We know iron absorption is retarded by phytate and antacids. We say that, but are we telling our patients? No, probably. We have to tell what we have done. I do not now have that. Actually, madam, we have prepared the dabbas. So what we are doing, we are giving that dabba to the patient. And on that plastic ka dabba, this is a very good dabba. माने almost it is of 9 by 6 inches. And ये ऐसा जाड़ी में 3 इंचेस का डब्बा है. हर एक पेशेंट को दिया जाता है फ्रॉम आवर क्लिनिक टू कीप देयर मेडिसिन. और उसके ऊपर ही ये सब लिखा हुआ है कि आपको आयरन की टैबलेट आपको नींबू पानी के साथ पीनी है, खानी है, और आपकी कैल्शियम की टैबलेट हमेशा दूध के साथ पीनी है, और आयरन की और कैल्शियम की टैबलेट कभी साथ खानी नहीं है. आई विल शेयर ऑन आवर ग्रुप कि किस प्रकार से वो डब्बा बनाया गया है. और तो ये डब्बा देखते ही उनको पता चलता है कि कौन सी टैबलेट कैसे खानी है. Iron tablets are ideally taken before meal or at least 1 hour after the meal. तो मैं सबको ये सिंपल आइडिया बोलता हूँ, खाना खाओ, आधे पौने घंटे के बाद नींबू पानी तैयार करो, खाना भी हजम हो जाएगा और ये गोली उसके साथ खा लेना. So that is the practice what I am doing and I have मैंने made by all ANMs, GNMs और सबको क्लिनिक में ये सिखा के रखा है कि जैसे ये डब्बा हाथ में दे आप दोगे तो उसके साथ इस प्रकार से बात करना, खाना खाने के बाद 1 घंटे बाद नींबू पानी के साथ ये गोली खाओ. फूड, टी, एंटासिड्स जस्ट बिफोर और आफ्टर द टैबलेट नहीं खानी है. अदरवाइज व्हाट पेशेंट्स डू, एंटासिड भी खाते हैं और उसी के साथ आयरन की टैबलेट भी खाते हैं. दैट विल रिड्यूस द एब्सॉर्प्शन ऑफ द आयरन. और फिर हमें लगेगा कि मैंने इतनी अच्छी आयरन की टैबलेट दे दी लेकिन पेशेंट को कुछ फर्क नहीं पड़ रहा है. पेशेंट को ये भी हम बोलते हैं कि आपको पहले 4 दिन एसिडिटी होगा, थोड़ा सा आपका जीआई डिस्टर्बेंस होगा, थोड़ा डायरिया होगा, चिंता मत करना, 4 दिन सह लेना. लेकिन अगर 5वें 6ठे दिन भी ये है तो आ जाओ, हम चेंज कर देंगे. लेकिन अगर ये नहीं है तो डोंट वरी. पेरेंटल आयन, सॉर्बिटॉल, डेक्सटान, पॉलीमोल्टोज, मैं इसके बारे में बोलूंगा भी नहीं. It is iron sucrose and FCM. Prerequisites: diagnosis must be confirmed. Adequate supervision facilities for the management of anaphylaxis must be there. And oral iron to be stopped 24 hours prior to therapy. That is very important to avoid the toxic reaction. बहुत बार ऐसे होता है कि आइए पेशेंट क्या होता है, नहीं. So we tell patient कि आपको आइए इंजेक्शन खाना है, 3 दिन गोली बंद करो, परसों आ जाओ, थोड़ा सा खा के आओ, एक रिलेटिव को लेके आओ, सुबह जल्दी आ जाना. एंड वंस ही कम्स देन वो पूरा प्रोटोकॉल, उनका कंसेंट लिया जाता है, एवरीथिंग इज चेक, शी इज पुट ऑन मॉनिटर एंड देन उसको इंजेक्शन दिया जाता है. वन सिस्टर स्टैंड्स देयर फॉर इनिशियल 5 मिनट्स, कुछ नहीं है देन शी विल डू अदर वार्ड वर्क. सो दैट इज कंपल्सरी एंड वी हैव मेड ए एसओपी ऑफ इट, आउट ऑफ इट. तो एक बार ये एसओपी किया और इस प्रकार से किया तो वी हैव नेवर कम अक्रॉस एनी कॉम्प्लिकेशन इन वन पेशेंट. पेशेंट सेड दैट बहुत खुजली हो रही है तो तुरंत वी स्टॉप्ड इट Immediately further things were done. Contraindications: first trimester of pregnancy, history of anaphylaxis, chronic liver disease. We all know this calculation of the doses. For that again there is a good app, that is Cross 11. थोड़ा सा ये मिल नहीं रहा था, तो नाउ आवर टीम इज प्रिपेयरिंग दैट ऐप, इट विल कम सून. मैडम ये जस्टोसी स्कोर का भी जो ऐप सबको नहीं मिल रहा है ये अपने एंड्रॉयड मोबाइल पे, तो इसका भी हमने सॉल्यूशन हल कर दिया. एक सिर्फ 4 पेजेस का वेब बेस्ड ऐप आ रहा है, तो ये एंड्रॉयड ऐप पे भी खुलेगा, लैपटॉप पे भी खुलेगा और एप्पल पे भी खुलेगा. बस 4 दिन में उसका इनॉग्रेशन हम करने जा रहे हैं. इसी प्रकार से ये क्रॉस 11 भी आ जाएगा फ्री ऑफ कॉस्ट इन द सर्विस ऑफ नेशन. आयरन सुक्रोज मैं बोलूँगा यूजुअली नहीं देना चाहिए, क्योंकि बहुत छोटा डोज है 100 एंड 200 मिलीग्राम. बट अगर थोड़ा ही देना है तो येस, बट ड्रिप रेट इज एडजस्टेड सो दैट टोटल ड्रिप कंप्लीट्स विद इन 30 मिनट्स. नॉट टू स्लो, नॉट टू फास्ट. और a schedule can be made to give 200 milligram twice in a week till the total dose is achieved. अगर हमें टोटल आयरन डोज देना नहीं है, या बहुत सारे PSCs में हमारे यहाँ पे ये फ्री ऑफ कॉस्ट दिया जाता है, तो आई एम गोइंग एंड टीचिंग ऑल दोज मेडिकल ऑफिसर्स कि किस प्रकार से दे दो ताकि एडवर्स ड्रग रिएक्शंस कम से कम रहेंगी. FCM, yes, it is recommended in the Anaemia Mukt Bharat operational guidelines. It is dextran free IV preparation. Again, preparation of the drip is very important. अगर हम, this is again no I mean my business, we have taken it from the pharmaco dynamics, kinetics, वो सब स्टडी करके जो लिखा हुआ होता है उसके हिसाब से. If we want to do 200 to 500 milligram of the FCM हमें देना है, तो then it is diluted with 100 ml of the normal saline. अगर हमें 500 तक देना है तो 100 ml नॉर्मल सलाइन में पहले क्या करते हैं, सलाइन लगा के थोड़ा 10 ml जाने देते हैं और फिर इसे उसके अंदर डाला जाता है एंड इट इज गिवन ओवर 6 मिनट्स. स्टॉप वॉच लगा के हम देते हैं. नो रिएक्शन हैज ऑकर्ड टिल डेट. अगर हमें 500 से 1000 तक देना है तो वी प्रिपेयर दिस इन 250 ml ऑफ नॉर्मल सलाइन. उसमें 10 से 20 ml ये माने डाला जाता है एंड इट इज टू बी गिवन ओवर 15 मिनट्स, बिकॉज अगेन दैट इज एब्सोल्युटली रिकमेंडेड इन ऑल दोज ड्रग किट्स, in all those company manuals and even in pharmacology books. So if we follow this 6 minute or 15 minute wala, we have never seen the reaction, because most of the time these are not the anaphylaxis reactions with FCM, but these are the iron reactions. Schedule can be made to give not more than 1 gram in a week till total dose is achieved. Again, madam, we have simplified it. हमारे यहाँ पे हर थर्सडे को ये दिया जाता है, तो यूजुअली पेशेंट को हम बोलते हैं कि ये थर्सडे आ जाना और अगले थर्सडे आ जाना. तो ऑलमोस्ट ऑल थर्सडे पे 4-4, 5-5 ड्रिप जब भी किसी को देने हैं, दूसरे डॉक्टर के भी हम दे देते हैं. तो ये यूजुअली वी डू ऑन दोज डेज. लास्ट, एडजुवेंट थेरेपी, डीवर्मिंग भूलना नहीं चाहिए. फोलिक एसिड, मोस्ट ऑफ द आयरन प्रिपरेशंस दे कंटेन 1 मिलीग्राम ऑफ द फोलिक एसिड. अगर उसमें नहीं है तो हमें एडिशनली 1 मिलीग्राम ऑफ द फॉलिक एसिड देना चाहिए, बिकॉज दैट इज अगेन गवर्नमेंट एडवाइस. B12, yes, 1000 microgram intramuscular every 4 weeks. If we give, definitely it corrects very fast. And protein, either in diet. Again, I am very much against of all these protein powders. Yesterday only I told my patient, उनको मैंने पढ़ने को ही बोला, तो 6-7 डब्बे लेके आए, सबके बारे में ये पढ़ा, तो हर एक में प्रोटीन का जितना क्वांटिटी है इनटू 4 शुगर और कार्बोहाइड्रेट का क्वांटिटी है. सो व्हाट इज दैट डब्बा? दैट डब्बा का नाम प्रोटीन का है, बट दैट डब्बा इज ऑफ कार्बोहाइड्रेट्स. सो वी एनकरेज पेशेंट्स टू ईट द पोल्ट्री एग्स, बिकॉज मोस्ट ऑफ द पेशेंट्स दे से दैट वी डू नॉट ईट नॉन वेज एंड एटसेट्रा. सो मैंने इस पर एक तरकीब निकाली है. मैं उनको बोलता हूँ कि आप पोल्ट्री के अंडे खाना, क्योंकि उसमें से तो बेबी नहीं आएगा. तो डोंट वरी, दैट इज नॉन वेजिटेरियन एग. because it is a poultry egg. जो वो भी नहीं खाते, फिर वो सोयाबीन, soya chunks, etc. But they will eat this natural source of protein and their diet advice as per need of the condition. So this was given. These are the further readings. I have taken the references from very recent, this Ministry of Health guideline November 14, then Foxy GCPR, and our Anemia Mukt Bharat. These are the indications of blood transfusion everybody know. So I think I have tried to cover the salient features or the important aspects of the anemia, and again the topic is open for the discussion so that we can make a turmoil and we can decide again how it can be simplified. Thank you very much, madam.
Thank you, sir. It's a wonderful elaboration. And really, you have revised for us so many points you told earlier. And honestly, yes, some points were forgotten. And they will be well taken now. I'll invite Dr. Shada Jain ma'am and then Dr. Vandana Bagga to give their expert comments.
I think, Dr. Gorakh, what should I say? You are epitome for innovation, thinking about it, making things very, very simple for people. Today's talk has been telling how in depth you have gone through this particular topic, and things are simple. I also feel there are many people like me here sitting that, they follow deworming, they give injectable iron whenever you find that the hemoglobin is 10 or below that. And unfortunately or fortunately, we don't see that kind of severe anemia in our practice at all now. And but Government of India says all patients of severe anemia, that is 7 gram. 7 gram is the critical cutoff. They must be hospitalized. They must be hospitalized in case they have, decompensation. They require blood transfusion, and thereafter these people can decide about it, whether the patient requires injectable iron and the other supportive things. You will not believe, Dr. Gorakh, for many years, we don't have a lady going for the delivery who has a less hemoglobin, less than 10 gram percent. If a patient has come late to me at, 35, 34 weeks, and, somebody says that you require a blood transfusion, do you require a cesarean section? वो कहते वो बड़ी मैडम को बात करके आएंगे, वहां पर जाएंगे. Then, it is possible that, people, our patients are not having a hemoglobin of 12 gram percent. And after your, recommendations that you give deworm to everybody, I have started giving deworm to everybody. And I think it makes sense. When she gets deworm, she gets motivated. Why not get my CBC also done? So, why madam is insisting, why madam is giving it free. And if she is giving it free, she probes and she says, let me get my hemoglobin done. So I think, it is not something very difficult at all. I think we have not put a mind on it. If you put a mind on it, then I think we will be able to do it. Like it's an off-label things. Whenever you see picture like emergency, you go to the hall and there are 10 people are sitting. Hall is vacant. So I think, unless our parents get inculcated whatever history of ours there, and we ought to know that, that kind of things are there. And I feel, if developed country is 2/3 of the globe, 2/3 of the globe has got hemoglobin less than 5 gram percent, then why are we lingering with 50? 50 to 70 में बोलूंगी, बच्चों में तो 70 के पास आ रहा है, लड़कियों में 60 के आसपास आ रहा है, because we are not serious. We are not serious. We have to have a passion for 4 crores of rupees which the government of India spent on us to make a specialist, and अपने कमरे के 4 तरफ लगाना चाहिए, जिससे कि वो सुबह शाम आपको आवाज करे कि हमें इसमें कुछ काम करना है. I think that is the kind of passion we need to have. I always tell, people who say, I want to become a doctor, I say, इसमें पैसा नहीं है. इसमें पैसा नहीं है, अगर आपकी डेडिकेशन है, अगर आप सर्व कर सकते हैं तब आप आइए इसके लिए. And that's the way things have to be done. I think I have taken too much of time. I think it's doable, very much doable. But Prime Minister can't do it. It is you and me have to do it. Our Dr. Vandana Bagga is here. She's Director General of Health Services, Delhi government. I was thinking, that in month of March, myself and 2-3 more people who are big, who have got the seats, like a lady who is the IMA president bani hai, jo abhi DGF ki president bane hai, we should go to her and tell her that हमारे बस इस स्कूल की लड़कियों की हालत ठीक कर दो और तो हम कर ही लेंगे. स्कूल की लड़कियों की हालत आप ठीक कर दो बस. So this is what my request is there. Dr. Gorakh, I am passionate about Anaemia Mukt Bharat, and I will put my all effort till I breathe last as far as these things are concerned. So Vandana Bagga, you want to speak something, Dr. Vandana?
Yeah, she's coming.
Thank you so much, ma'am. This is my privilege to listen to you all the time, and Dr. Gorakh for a very, very wonderful talk that you have given for such an important topic. And I really appreciate the way you have made it very simple. So I was a student of Dr. Shada Jain, ma'am, like most of us. And the best part was that she used to make things very simple. So the things that I remember after 4 decades, that is the power of making things simple. So this is something which is need of the hour right now, and very simple things and very important thing, like you have said, sir, that don't ignore the mild anemia. And very simple steps can really make a major difference in the overall impact of the thing. So anemia definitely is the top public health problem right now, not India, in Delhi itself. And I think all of us need to contribute to that. Ma'am has already said that Prime Minister cannot do that. This is we, the people who, as each and every member of the team, must contribute towards it. Irrespective whether you are a gynecologist, whether you are a doctor, you are part of the community, and we must spread the message across. So thank you so much, ma'am, for always being there. And thank you, Dr. Gorakh, for such a wonderful thing. Dr. Vanna, the whole forum is doing wonderfully well.
Thank
And
you.
I will definitely remain a part of your team wherever I am, irrespective of that. So
Thanks.
thank you so much.
Thanks a lot.
Dr. Vandana, what it is needed is you find that the iron is surplus there in your hospitals. Only 1/3 of the gynecologists are confident in giving injectable iron. Now the message is not only Shada Jain and Dr. Manjupuri speaks, but I think Dr. Gorakh also says, if the hemoglobin is 10 gram%, it is time for injectable iron to say goodbye to oral tablets after that. So to other people for expert.
And your presentation earlier, in earlier deliberations, you had made it very clear that the reserves go zero first and then anemia comes. So if the patient is anemic, her reserve is already gone. So we need to, that is the reason why we need to give them therapeutic doses so that their hemoglobin comes up. And the tip Dr. Gorakh gave, that give with nimbu pani, and people are very passionate about nimbu pani. And they will take it they will accept it very nicely. 1 घंटे बाद खाना हजम हो जाएगा, गोली खा लेना उसी में चुपचाप से, उनको पता भी नहीं चलेगा कि हमने गोली खाई थी. मैम आप म्यूटेड हैं. मैम आप म्यूटेड हैं.
हाजमे की गोली उनको बोलना पड़ेगा.
हाजमे की गोली, exactly. That was a wonderful tip. So Dr.
मैं तो मैडम ये एनीमिया के बारे में उनको जब मैं काउंसिल करता हूँ तो उनको हमेशा यही बोलता हूँ कि if you want to see your baby like Prime Minister or our like राष्ट्रपति, तो बस आपका हीमोग्लोबिन 12-13 होना चाहिए, नहीं तो गुंडा पैदा हो जाएगा. तो बस ऐसे बोला तो वो दिन से वो सर इसका कोरिलेशन क्या है. तो बस मैंने if we do like that, तो मुझे ये लगा कि छोटी-छोटी चीजों में से it is impacting them, so it is easy for them.
Yes. So Dr. Raka
And Dr. Vandana, I am ready to give 1,000 lectures where I teach these. Your hemoglobin may be 12 gram plus, but still your all stores exhausted. Your
Exhausted,
bone
yes.
stores are exhausted, your functional stores are exhausted.
Exhausted.
So don't be carried away कि मेरा hemoglobin 12 है तो मेरा सब कुछ ठीक
Yes,
है.
yes, yes.
तब तक तो सारा सत्यानाश हो ही गया है.
Absolutely,
मैडम
absolutely.
इस पे मैं एक कहना चाहूँगा कि यहाँ पे इतने सीनियर्स है एंड दे आर फ्रॉम डिफरेंट पार्ट्स ऑफ द दिल्ली. सो जहाँ पे ऐसा रिपोर्ट आता है, माने जो हम स्टडी कर रहे हैं उस प्रकार से कि wherever the hemoglobin is between 11 to 12 and MCV is low, तो in such patients let us check the ferritin. तो थोड़ा सा क्या होगा कि एटलीस्ट वी कैन कम अप विद द डेटा. हर एक ने अगर सिर्फ 10 पेशेंट भी दिए तो भी काफ़ी है. तो द डेटा विल बी जनरेटेड कि हीमोग्लोबिन बिटवीन 11 to 12 विथ लो एमसीवी, फेरिटिन इज वेरी लो. सो एक बार ये डेटा आ जाएगा, देन वी कैन मेक इट सब लोगों के सामने कि अरे इट इज रियली डेंजरस एंड वी हैव टू चेक इट द आयरन एंड गिव द आयरन. सो मुझे लगता है कि एक छोटा स्टडी हमारे ग्रुप का दिल्ली गायनेक फोरम का हो जाएगा. हर एक ने सिर्फ 10 पेशेंट भी दिए तो मैडम ये कंपाइल हो जाएगा एंड अंडर योर लीडरशिप दैट कैन बी कंपाइल्ड टुगेदर.
We can get it done. Shakuntala.
Good afternoon, everyone, and thank you for this opportunity. It was a fantastic lecture, Dr. Gorakh. There are a few things that I noted, and it was very, very pertinent. When you said that subsequent anemia in pregnancy, when you are giving iron, and you come to know that the iron levels are still, the hemoglobin levels are still falling, it was a very pertinent point that you raised, that there are depleted stores and we did not take care. And there is the importance of this preconceptional and premarital counseling.
Yes.
When these girls come and we check the hemoglobin and we make sure that the hemoglobin levels, once they rise, 6 months more of iron therapy is to be given so that the iron stores are replenished. That is very important. Second is the source of iron. Which iron is good? Well, sir, in my practice, ferrous fumarate, ferrous sulfate, these are good forms of iron. And lastly, the Menzer index, did I miss it? Was it mentioned? The Menzer index?
No,
I not mentioned.
Yeah. So I think that is also a very good way of finding out if it is more than 13, then it is probably iron deficiency anemia, and if it is less than 30, probably we are dealing with a thalassemia, minor form of thalassemia. Lastly, the treatment, when we are giving treatment to these girls, you did say that lemon should be taken. Gooseberry is also a very good source of iron. But then आजकल तो कई बार ऐसा होता है कि किसी को कुछ नहीं लेना तो हम बोलते हैं भाई तुमने जो कोविड में लिम्सी इतना चूसा था तो एक टैबलेट लिम्सी की भी साथ में ले लीजिए. Along with iron, take one tablet of vitamin C as well. So if people are not taking lemon or gooseberry, then we do tell them to take that. Along with that, B complex is never to be forgotten, because vitamin B12 deficiency simultaneously or dimorphic anemia does exist, which you very rightly pointed out. Thank you very much.
Thank you.
Dr. Renu, you want to say something, Dr. Renu?
Yes, ma'am. As we know that diet is very important, so जरूरी नहीं है कि patient महंगी चीजें खाए, as Dr. Gorakh has already pointed out. So we should tell them about the green leafy vegetables and the seeds he has talked about. I think that is very, very important.
Dr. Tharoor?
That article has to be read. Dr. Gopalan had been the director for many, many years of National Institute of Nutrition, Hyderabad. It is his article.
Right.
Yes, ma'am.
It is his article.
Yes, madam.
He was very passionate about two things: folic acid and telling about the diet,
Yes,
which is indigenous of this particular country.
Yeah.
Dr. Anita Rajoria, you want to say something?
Yes, ma'am. I think sir has covered everything comprehensively. Very nice, simple carry-home messages that obstetrician can follow, and